$4.8 billion. This is the amount of money that is spent on excess acute care inpatient costs. But for what disease state? Hi, my name is Rachel Larmer, and today we'll be discussing the comparative efficacy of oral vancomycin and metronidazole in the treatment of non-severe Clostridioides difficile infections in hospitalized children. After watching this lecture, you'll be able to identify the risk factors, pathophysiology, and diagnosis of pediatric CDI. You'll also be able to interpret current guideline recommendations on the treatment with metronidazole and vancomycin and infer differences between these two treatments. First, we'll start with epidemiology and risk factors, and we'll go to the pathophysiology, diagnosis, treatment, supporting literature, and we'll close it out with a summary. As we go through this presentation, it's really important to remember that Clostridioides difficile is a naturally occurring bacteria in your normal flora. The symptoms and infection is only the result of out-of-control colonization. And it's an always changing epidemiology because there's constantly new strains that are emerging. Also, it can be from the community that you contract this, but it's usually the result of hospitalization. Epidemiology and risk factors. It's the most commonly recognized cause of infectious diarrhea in healthcare settings, and it's responsible for over 500,000 infections annually. However, the exact magnitude depends on the type of diagnostic test that's used. There are efforts to control and prevent this disease, and hospitals can be rewarded with incentives for public reporting and also do pay for performance. In children, it's important to consider the colonization. So the rate of colonization of C. diff decreases with age in children. In infants, it's around 70%, but by 2 years old, it decreases to 3%, which is the healthy adult range. And children may also have asymptomatic colonization, where they have both toxic or non-toxic strains in their body. But it's also important to realize throughout all of this that a high colonization rate does not necessarily mean that the patient has an active disease. There are different risk factors that can lead to contracting a CDI or C. diff infection. First is antibiotics. This is especially those third and fourth generation cephalosporins, fluoroquinolones, carbapenems, and especially clindamycin. Another risk factor could be hospitalization, especially one of long duration, any manipulation of the GI tract, so like surgery or the presence of a tube. And then a lot of people have wondered if antacids like proton pump inhibitors and H2 antagonists could be an additional risk factor for contracting a CDI. And it's possible because stomach acid is a protective mechanism for these infections occurring. So when you take that away by taking antacid therapy, it's possible that it could produce an infection. Pathophysiology. So Clostridioides difficile is a spore-forming gram-positive anaerobic bacillus. The infection is caused by the toxic strains, which are A and B. And this is a contagious infection. So this wheel is constantly moving from person to person. It starts with the transmission, which in the healthcare setting, it could be person-to-person spread, so like nurses' hands or other healthcare providers. And then it's usually through fecal-oral route, or it could be from direct exposure. So that could be to different equipment or supplies in the hospital. And then the spores, which are on those hands or the equipment or anything, gets ingested into the body. This is that fecal-oral route. So then here it passes through the stomach and it germinates in the bowel, which is where the vegetative form colonizes. And then that vegetative form is going to proliferate. Something that could really lead to it being easier for it to proliferate is antibiotic therapy because it disrupts the normal flora. So it takes away those protective mechanisms. And then it's here where it produces its toxins, which then attach to the intestinal brush border on receptors, and it causes the cells to die and necrosize and shed into the lumen. Toxins also attract inflammatory cells, which damage the epithelial cells. This produces pseudomembranes and watery diarrhea as a result of the expulsion of the cellular debris and the mucus. So here's a really good image of the damaged epithelial cells. We can see the spores in the vegetative cells here in the stomach moving through the small bowel into the colon. And then we have a really good close-up view here of the vegetative cells coming into the epithelial, killing off our cells, and they necrosize. And then we have the pseudomembranes and the mucus coming out. Diagnosis. So diarrhea is really common in kids. So it's really important that before we perform these diagnostic tests, we know that if they're aged 1 to 2 years old, that we've excluded all other causes of diarrhea, or that if they're 2 years old or greater, that the diarrhea is prolonged, worsening, and that they have a risk factor like hospitalization, antibiotic therapy. All of these tests have pros and cons to them. Nucleic acid amplification tests are newer and they're more expensive and they're rapid. And they usually produce pretty good results. However, the other tests listed here, like the immunoassays, are ones that might take a little bit longer to perform, or they may need a second confirmatory test to be performed so that we know that the results are correct. Treatment. So here we can see that in children, both metronidazole and vancomycin can be used to treat in all different categories, such as initial episode, recurrent episodes, severe or fulminant, which is rapid onset, or second reoccurrences. And we can see here which categories are appropriate. For example, an initial episode where it's severe, we cannot use metronidazole as a monotherapy. We can only use it in combination with vancomycin. And then we can see that in a second or subsequent reoccurrence, that metronidazole is not used at all. We actually only use vancomycin and perhaps another therapy. Next, we have the pediatric dosing. This is a really good outline from the guidelines that came out in 2018 from the IDSA and SHE. So here we have another outline of the different categories along with the recommended treatment, the dosages for that treatment, the maximum dosage, and the strength of the evidence. Notice here that the only one that has a strong or moderate level of evidence is with vancomycin in initial episode severe. All the other ones are weak and low. Here we have a comparison of the treatments. So we go through the mechanism of action, which is very different for the two different drugs. As far as the pharmacokinetics, it's really important to point out that vancomycin actually has poor absorption, low distribution, remains in the intestinal tract, and is excreted in the feces. Looking at this, you might think, that doesn't seem like a very good drug. It doesn't seem like it would work. But it actually is why it works and why it's efficacious, is because it's targeting where the infection is in the intestine and the feces. It's also important to notice that metronidazole has a very big disulfiram-like reaction with any type of alcohol. Supporting literature. So there was a systematic review and meta-analysis that was published in 2015. It looked at 17 different studies from 13 articles and enrolled over 2,500 patients. It found that metronidazole and vancomycin were equally efficient for treatment of mild CDI. And it also found that vancomycin is better for severe CDI, and combination therapy is not superior to monotherapy. However, we do have to question the results of this because there wasn't really a lot of inclusion-exclusion criteria of their studies since they used no publication status or other restrictions. Also, this study only looked at adults. You're going to see that there's very, very little evidence in children, and a total lack of studies are done to look at CDI in children. So it's really hard to find any evidence of how we should treat them. In summary, there are conflicting guidelines. Just this past couple of years in 2018, the IDSA posted an update to their treatment guidelines for adults. And it changed so that it strongly recommended the use of vancomycin over metronidazole as first-line treatment for adults. And this is for non-severe cases. However, there is a lack of evidence in the pediatric population, and that recommendation did not change in 2018. So they still have a weak recommendation for both metronidazole and vancomycin for non-severe infections in children. However, both of these are low quality of evidence, whereas the vancomycin has a strong level of evidence in adults. It also is important to point out that in children, there's a strong recommendation for vancomycin in severe cases. So this is due to the risk of poor outcomes and the strength of evidence in adults. So we can see that those two do agree. In conclusion, increased research in the treatment of pediatric CDI will give us more evidence on how we should treat the children to prevent future infections. This is a recurring disease, and once you get a CDI infection, you are more likely to get it at another point in life. So helping to pick our treatments and pick the most efficacious treatment for these kids is going to help to prevent those future healthcare dollars being wasted on future treatments and just to decrease all of those costs in general. Here are my references. Thank you for listening.